So I've been inspired to make another physiology animation for the ages. This is a follow-up to the first vodcast I did on IVC collapse that went out to emcrit.org, and I received some comments from Dr. Merrick, and I wanted to use this opportunity to get a little bit more into the nuts and bolts of IVC collapse using Guytonian physiology. So before watching part one, I suggest you watch the first part, which is more of a cartoon approach to IVC collapse, before diving into this. This is an animation which also explains some of the physiology between IVC collapse and the application of positive end expiratory pressure, based around some findings from an article in 2012 by Yule Olson and colleagues. Lightning bolts of knowledge return. So let's get on with it. This is Guyton and collapse. X-axis is the right atrial pressure. This is atmospheric pressure, labeled as 0. Everything above it to the right here is positive, below it is negative. The y-axis here is blood flow, and that could be either venous return or cardiac output, as we will see. So this point here, very important point, this is the mean systemic filling pressure. This is the pressure in that waterbed looking thing that I animated in the first part. It's the elastic recoil pressure of blood pushing against the venous capacitance beds. And it is the pressure in the circulatory system when there is no flow, hence it is the x-intercept. So that is the symbol for the abbreviation for mean systemic filling pressure. So what happens when we start to lower the right atrial pressure for a given mean systemic filling pressure? Well, you can see here this is what Guyton did in the 50s, where he experimentally lowered the right atrial pressure, and you had essentially a linear increase in venous return being pushed into the right heart from the upstream pressure head, which is the mean systemic filling pressure. As you systematically lower the right atrial pressure, you get an increase in flow on the y-axis until you hit this part right here. And this is very important. This is a Starling resistor. This is the generation of vascular waterfall physiology. And this occurs when you have a distensible tube and the pressure within the distensible tube falls below its ambient pressure, and you get this plateauing of flow. It is not a cessation of flow, but it is a plateau of flow, and this is essentially IVC collapse. It occurs cyclically and rapidly, and it puts a speed limit on how much venous return you can get. And so this is what it looks like as the cartoon of the venous return curve. So let's add some PEEP. And what PEEP does, interestingly, and is often unrecognized, is that PEEP increases the mean systemic filling pressure. And PEEP increases this pressure by a few mechanisms, but primarily through adrenergic response. So the application of positive pressure to the chest releases adrenaline and noradrenaline, and it clamps down the venous vasculature, and it recruits unstressed volume into stress volume, and increases the mean systemic filling pressure. PEEP also redistributes blood from the thorax to the systemic circulation, the venous bed, so it tends to increase this pressure head. And then when you start to systematically lower the right atrial pressure when PEEP is applied, and this was done in the early 90s in Henry Fessler's lab, or I guess it's Salt Permit's lab, but a classic paper by Fessler and colleagues, is that you notice a couple of things here, is that the mean systemic filling pressure is increased, and there tends to be, for a given right atrial pressure now, if you compare this right atrial pressure to this right atrial pressure, they're the same, but there's actually more inflow here. And that's just because the pressure head has increased, as it is here. So there's more venous return coming in. But the interesting thing is you start to get this vascular waterfall or Starling resistor physiology at a lower maximal venous return, comparing this to this. And the critical collapsing pressure, the pressure at which the great veins begin to collapse, occurs at a higher pressure compared to atmospheric pressure. And the mechanism by which this occurs is probably, and it's complicated in humans compared to dogs, because dogs have intrathoracic IVC and humans don't, as you see on an ultrasound. Our IVC goes directly through the liver into the right atrium. But the mechanism by which this occurs from PEEP is probably pressurization of the abdomen. And it's a bit complicated because it depends on the pressure in the abdomen, on the hepatic surface pressure, and the portal venous return, in distinction to the pressure around the non-portal venous return. So portal venous return is from the splanchnic beds moving in through the liver and then draining down through the hepatic vein into the IVC, versus the non-splanchnic venous return is essentially everything coming up from the IVC, the renal veins. The differences between those two, and pressurization probably more readily causes collapse of the non-portal venous beds. But in any case, the important thing to recognize is that the pressurization applied by PEEP causes this lowering of the maximal venous return. And so this is the stylized curve from PEEP on venous return. So keep that in mind. So now let's move on to our cardiac function curve. This is the Frank-Starling curve. And this point down here is very important. This is the intrathoracic pressure. And normally, intrathoracic pressure or pleural pressure is slightly negative because at functional residual capacity, there's this outward expansion of the chest wall and inward collapse of the lungs, and the recoil pressure is equilibrated at this slightly negative pressure. And so when intrathoracic pressure changes, the cardiac function curve changes with the intrathoracic pressure. And this is sort of like the cartoon that I showed in part one, the heart raising and falling relative to some sea level. And here we'll call sea level here atmospheric pressure. So when intrathoracic pressure rises, then the whole cardiac function curve will shift rightwards. And that's exactly what the application of PEEP does. And so how much does the intrathoracic pressure rise in response to PEEP? Well, that's a whole other lecture in and of itself. But the pressure that's applied to the proximal airway is used to lift the lungs and the chest wall together. And in health, and again, I want to emphasize in health, the chest wall and the lungs have kind of similar compliances. So the amount of pressure applied at the airway, about 50% of it goes to lifting the lungs, and another 50% of it kind of goes to lifting the chest wall. So roughly 50% of it ends up in the pleural, as an increase in the pleural pressure. So let's go back to our baseline. And now let's look at the Guyton diagram, which is the superposition of the Frank-Starling curve and the venous return curve, and they come together here at the right atrial pressure, as you are well aware. So what happens when we apply PEEP now? So there'll be the PEEP effect on cardiac function, there'll be the PEEP effect on venous return, so the cardiac function curve shifts rightwards relative to the atmosphere, and the venous return curve changes, as we talked about previously, and you can see that the operating point of the cardiovascular system, which is where the cardiac function and venous return curves intersect, may not change all that much. So if you see, this is the total amount of blood flow for this state of the cardiovascular system, and this is the balancing point between venous return coming into the thorax and cardiac output ejecting blood from the thorax. If you compare this level of total cardiac output to the application of PEEP, it may actually be quite unchanged, and that's because the increase in intrathoracic pressure has diminished the inflow of venous return by raising the right atrial pressure, but at the same time you've increased the pressure head, so it may be kind of a wash. So this represents the application of PEEP. But now when this patient inspires, so this is end expiration, right? So that's, you can sort of imagine the initiation of PEEP in this patient leads to this new operating point. But then when the patient inspires, intrathoracic pressure, so this point down here, falls again as the diaphragm contracts. And what you see is you have a state that is more prone to this vascular waterfall or Starling resistor physiology. So there is more likely a an IVC collapse here. And that's important, because when we consider a state of high PEEP, so let's say this is the application of 20 centimeters of water of PEEP, which was done in the Ewell-Olson trial. So let's say that, going back a couple, let's say this is the application of 10 of PEEP, the first level of PEEP that was applied in that trial. So you apply 10 of PEEP, the cardiac function curve shifts rightwards, the venous return curve changes, so there's no real change in cardiac output. The right atrial pressure rises, and you get to the situation where IVC collapse is more likely. And indeed, the application of 10 centimeters of water of PEEP in that investigation in healthy volunteers laying in the horizontal showed that there was an increase in IVC collapsibility moving from 0 to 10 of PEEP. So you may see physiology like this when they inspire. Now let's consider adding 20 centimeters of water of PEEP. So now you've accentuated the venous return effect. So you've really increased the mean systemic pressure, and you've increased the critical collapsing pressure. And at the same time, you've increased intrathoracic pressure to a greater extent. So you'd say, well, shouldn't this patient be collapsing throughout the respiratory cycle here when they inspire? But here's the kicker, and as I describe in the blog post, PEEP not only raises the ambient pressure around the heart, raising the intrathoracic pressure, PEEP can also affect cardiac function, particularly by afterloading the right ventricle. And this really starts to get to be a problem when you get PEEPs certainly above 15 centimeters of water, when this increase in airway pressure starts to cause West Zone 2 physiology, and I describe a little bit of that in the post. But essentially this physiology occurs when the alveolar pressure supersedes the pulmonary venous pressure. And the effect of afterloading the RV is to bend the cardiac function curve down and rightwards. So even though you've increased the intrathoracic pressure and venous return, as just illustrated, you may have a bending of this cardiac function curve, raising the pressure, and for lack of a better term, distending the right ventricle. So now when this healthy volunteer starts to inspire, they may not start on this collapsing portion of the venous return curve, so you may actually only see a little bit of venous collapse, if anything. And indeed, in that trial, there was a suggestion of that. The application of 10 centimeters of PEEP tended to increase IVC collapsibility, and then when you got to 20 centimeters of PEEP, there was a suggestion that collapsibility diminished. And again, that is only through changing levels of PEEP. It has nothing to do with changes in the patient's volume status per se. Another important consideration is this idea of volume responsiveness. Now, this patient would be volume responsive because the venous return curve is intersecting the ascending portion of the Starling curve. But if you start adding too much PEEP, you may actually shift this right heart into its volume non-responsive portion. So you're now actually on the plateau portion of the cardiac function curve. Yet when this patient inspires, you may actually start to pull it onto the Starling resistor portion of the venous return curve and start to generate collapse, even though this patient is euvolemic, as in the study, and has an increase in IVC collapsibility. This patient nevertheless could be volume non-responsive simply as a consequence of an increased RV afterload. So let's go back to our baseline state. So this is the baseline Guyton curve, venous return, cardiac function, meeting in the middle. That's the right atrial pressure here, a given blood flow for a given right atrial pressure. So this patient breathes in, you see IVC collapse. This is the healthy person breathing in. But now let's consider another portion of their study. So I encourage all of you to check out Figure 4 in their investigation. And what they did in the healthy volunteers is, in one portion, they put them in Trendelenburg and gave them a liter of crystalloid. So that would certainly increase their mean systemic filling pressure to a large degree, and the effect of PEEP would start to lower the maximal venous return, as was just illustrated, along these lines. So you have a very high mean systemic filling pressure because now they've had unstressed volume recruited into stress volume of increasing the mean systemic filling pressure by placing them in Trendelenburg, plus you've given them a liter of crystalloid. So you really should increase that mean systemic filling pressure to a great degree. And in fluid-loaded cardiac surgery patients, I talked about this in my mean systemic filling pressure post on pulmccm.org, estimates of mean systemic filling pressure in those patients got up to about 20 millimeters of mercury. So this patient, this healthy patient's venous return curve may be shifted way rightwards now. There's a great increase in the pressure head for venous return or venous inflow to the thorax. But now this patient's lungs, because they're fluid loaded and in Trendelenburg, are predominantly in West Zone 3 physiology. So now, despite the high PEEP, you're not going to get that bending down of the right ventricular cardiac function curve, because all of the lung is in West Zone 3, because, as I said, the patient's in Trendelenburg and now volume loaded. So when this patient inspires now, you may actually see a similar amount of collapse as the baseline state. So this is the healthy volunteer in the horizontal non-fluid challenge. So they breathe in and they bring the right atrial pressure below the critical collapsing pressure. In this situation, the critical collapsing pressure is atmospheric pressure. And you pull yourself onto the flat portion of the venous return curve, which is Starling resistor physiology, and this is when the IVC collapse. You take that same patient, you put them in Trendelenburg, and you give them a liter of fluid, and you've greatly increased the mean systemic filling pressure and venous return, but you've also increased the intrathoracic pressure from the high PEEP and shifted the cardiac function curve rightwards along with it. And because of this increase in the critical collapsing pressure with the increase in PEEP, now this patient inspires, and the degree of collapse may be surprisingly similar to the baseline status. And in fact, that was what was seen. Those patients were placed in Trendelenburg and given a liter of crystalloid. Their IVC collapsibility diminished, but with progressive increases in PEEP, collapsibility increased. The IVC collapsed more readily solely as a function of increasing PEEP, lending credence to this hypothesis that this is what is happening as the abdomen is pressurized. So I hope that this was a not terribly confusing run through of venous return and cardiac function and how it applies to the application of PEEP, and it highlights the complexity of using IVC collapse as a marker of both volume status and volume responsiveness. Where that Starling resistor physiology occurs doesn't necessarily tell you if you're on the ascending portion of the Starling curve, as I tried to highlight there. Similarly, where that Starling resistor physiology occurs cannot tell you a patient's volume status by any stretch. Thanks.